You also want to deal with patient preferences. We do want to get their disease under control. We want to make them live a long, good quality of life. But do they want to come to the clinic once a week? Is it a far distance? Is geography a problem? Do they prefer not taking oral chemotherapies at home? I mean, we have to kind of think about what the patient's preferences are to some degree and kind of incorporate that in our decision-making plan for treatments for relapse and refractory myeloma.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between.
Hello, and welcome to the ONS podcast. I'm your host, Lenise Taylor, oncology clinical specialist at ONS, and today we're talking with Ann McNeill, nurse practitioner at the John Theurer Cancer Center at Jersey Shore University Medical Center in Neptune, New Jersey, about multiple myeloma treatment considerations for oncology nurses. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for guest disclosures before listening. Following the episode, complete the evaluation linked in the notes. Thanks for joining us again, Ann.
Oh, it's my pleasure. Thank you, Lenise.
Welcome back. Let's start with treatment and how it's initially initiated for patients with multiple myeloma. Can you talk a little bit about when we start treatment and if it looks different for patients who present as symptomatic as opposed to asymptomatic?
As we all know, some patients with myeloma are very symptomatic at presentation, and there are some patients who are asymptomatic at presentation. When do we start treatment for patients? In general, when they are symptomatic or have any evidence of end organ damage, we start treatment emergently. So we are going to want to prevent further organ damage, and you want to prevent these patients from getting sicker. So we do tend to focus on starting treatment right away for the patients who are symptomatic or, like I said, have any evidence of end organ damage. It can look a little different for patients who are asymptomatic. And, we have a new diagnostic criteria for myeloma. It used to be all CRAB criteria, right? So patients had elevated calcium or renal dysfunction or anemia related to the gamopathy or bone disease. We were rushing to say, wow, we need treatment. Let's treat them. But now we have the slim CRAB. So we have a couple of other diagnostic reasons to treat a patient who may not be sick, who may feel totally well. And those are the patients who have over 60% plasma cells in their marrow, or they have a free light chain ratio that is elevated over 100, or they have MRIs that are abnormal. So for these patients, I think it's a little different because there's still some debate about whether or not to treat these patients and what are we treating them with. So I think it's a very important conversation that these patients have with their provider to determine what route to go. The reason why we instituted the slim CRAB criteria was because we knew that patients with some of these other characteristics, like the higher percentage of plasma cells and elevated free light chain ratio, we knew that these patients invariably would lead to active myeloma. And we were kind of just sitting back waiting for them to get sick. So we said, well, instead of waiting for their organs to be damaged, let's jump on this and treat them first. But it's still debatable because we are treating high-risk smoldering myelomas. But now with this new criteria, we just have to kind of think about what our goal is. Are we going to wait a little while? Are we going to start right away? And like I said, that's a discussion for the patient to have with their providers and the whole team, the whole myeloma team.
That's so wild that we've gotten to a point where we can decide. We don't just look at numbers. We're looking at the patient. We're looking at what we know about this, and we can make decisions based on all of that rather than just jumping right in. Can you give us a brief overview of some of the first-line therapies that are used to treat multiple myeloma?
I remember many, many years ago when I first started treating patients with myeloma, our go-to regimen was high-dose dexamethasone. So I'm kind of aging myself here, but there have been many, many more treatment options since then. And typically for our first-line therapies, we use certain classes of drugs, and some of them are proteasome inhibitors like bortezomib and carfilzomib. We also have IMiDs or immunomodulatory agents like thalidomide, lenalidomide, and pomalidomide. We have monoclonal antibodies, the anti-CD38 monoclonal antibodies. Of course, we can never talk about treatment for myeloma without mentioning dexamethasone. It is really an integral part of our treatment regimen. And I do want to point out that most of our frontline or first-line therapies now are not just a single agent. They're not even doublets anymore. Typically, they're triplet therapies. And now in 2026, it's leaning more towards quadruplet therapies. So by that, I mean you're taking a proteasome inhibitor and an IMiD and dexamethasone and an anti-CD38 monoclonal antibody all together to present patients with a good chance. Their induction therapy will lead to a good chance of them responding to treatment and giving them their best durable response and their best remission. And of course, we have to think about autologous stem cell transplant. Autologous stem cell transplant is still considered in many institutions as frontline therapy. And by that, I mean patients are given induction therapy. So they're given that triplet or quadruplet therapy for a few cycles, getting their disease under control. And then we're giving them therapy to collect their stem cells and then giving them melphalan. So melphalan, high-dose melphalan is a very good treatment for myeloma. It's been a very good treatment for myeloma and still has a lot of efficacy in treating myeloma. And the only way we can give that kind of dosing of melphalan is to salvage the patient with their stem cells. So again, that's another discussion that the patient has with their team, is whether or not they're going to proceed on to potentially an autologous stem cell transplant.
I'm right with you on the high dose dexamethasone and aging me. So, and just the thought of that evolution of how we've added and added and added so that we can hopefully hit that myeloma from multiple angles and have fewer toxicities than what we might see if giving with single doses. We talked about the evolution. Are there other ways that these treatments have evolved over time?
I think the biggest factor is what I've already mentioned, where we used to just do single therapy. And then, it was, doublets. It was Rev-Dex. And then we had the proteasome inhibitors and we give bortezomib and Dex. Now, I think that the evolution of combination therapy, so really pairing these different classes of agents together to synergistically achieve the best response to get the myeloma under control. That's what I think is the way these treatments have evolved over time the most, is going from 1 or 2 agents now to 3 and now 4 agents. Now quadruple therapy is kind of common. Never used to be, but now it's patients when they get diagnosed, we're giving them information about a lot of different drugs, not just 1 or 2. So that's the way I think the evolution has changed dramatically in my eyes over time.
It's pretty cool. What are some of the adverse effects that we might see from these therapies besides what we would normally see with our normal therapies? And how can nurses provide supportive care for these?
I think as oncology nurses, we're all familiar with the array of symptoms that are fairly common with a lot of different classes of chemotherapy. We know fatigue is going to happen. We know cytopenias, alterations in other chemistries can happen. GI disturbances we know can occur. But I think uniquely for the anti-myeloma therapies, we have some of the classes that can have some very unique side effects. For instance, the proteasome inhibitors, specifically bortezomib, especially in the beginning when it was given intravenously, was associated with a significant risk of sensory peripheral neuropathy. So that was something we really had to deal with our patients, is how to manage, control, and treat the neuropathy that patients were experiencing. And then it went to sub-Q administration, which actually improved the incidence of that. So that was a big help. But patients still do get peripheral neuropathy. And for the drugs like the immunomodulatory drugs, for instance, lenalidomide, we have to think about the increased risk of blood clots. How do we manage that? How do we counsel patients on what to report, why and when and where? Looking for swelling in their legs or pain or warmth or redness, putting them on anticoagulation prophylaxis is important. So I think those kinds of things are important to note. And even with the monoclonal antibodies, maybe not a clinical symptom for sure, but there are some lab changes that we have to be aware of, because the anti-CD38 monoclonal antibodies can affect the patient's blood bank specimen. So it doesn't really interfere. They can still get transfused and it doesn't interfere with their transfusion, but it actually interferes with the blood bank technician's ability to cross-match appropriately. So the blood bank needs to be aware if patients are on any of the anti-CD38 monoclonal antibodies, because there is some interference with red cell antigen testing. So those kinds of things are very unique to these lines of therapies that are used to treat myeloma in the frontline setting.
I had forgotten about the cross-matching issues, and that's a really good thing to point out for people to be aware of, especially if they're not treating these patients commonly. What kind of responses should nurses watch for to show that these treatments are working?
So I think that nurses are very aware of their patients, and especially with myeloma patients who will be with us for a pretty long term, for the whole journey of their disease, which is usually a lifelong journey. I think that if we see them improving clinically, if we see them coming in maybe with less pain and a better spirits, less fatigued, I think this is kind of a hint that maybe the treatment is working, right? I think that the ultimate answer to that question is the nurses are going to look at certain labs, right? You're going to look at the CBC specifically. Is the patient's anemia improving? Is their hemoglobin? As they kind of respond to treatment, we do expect that their cytopenias are going to slowly, even though some of the drugs can cause cytopenias, when there's disease control, we do expect that the blood counts to become more normalized. And even their myeloma labs, which should be done, there should be some indication after each cycle of therapy that the treatment is working. So you don't have to do a whole myeloma panel, but maybe getting an M spike, maybe getting the free light chain assay, or maybe an IgG or IgA level, just to see if the treatment is working. So those labs are crucial to determine whether the therapies are working. And again, the lab improvements usually correlate with the clinical presentation of the patient. A patient whose M spike is going down after treatment usually will have less symptoms when they come to the clinic. That, like I said, less fatigue, maybe even less bone pain. They might just be doing better overall. And then the nurse can say, wow, this looks like it's really working.
I like the thought that fatigue could actually be improved during treatment instead of causing more.
I think initially when patients always start a treatment, I think it's fear of the unknown. And it is fatiguing to have to go to the clinic and get treatment. And some of the treatments are inherently fatiguing. But I think as we get better disease control, anemia improves, pain gets better. And I think overall, there's an improvement in activity. Patients can have less fatigue and do more, even though initially they may be compromised.
So on the reverse of this, if the patient isn't showing a desired response to treatment, what nurses need to watch for or expect to be adjusted?
If the myeloma team is seeing evidence of treatment not working, and by that, I mean, again, looking at the labs, looking at the patient. You're giving patients, treatment with 3 and possibly 4 drugs. And after a cycle or 2, you really do expect to see some improvement in the patient. If you see that they're not improving, that might be a sign that they're not responding to the treatment. And I think what that means to me as a provider or as part of the provider team is there might need to be a treatment change. We never really continue patients on the same exact treatment combination if we have evidence that it's not working. So for instance, if I'm giving a patient a triplet therapy or even a quadruplet therapy, and after a cycle or 2, I'm not seeing a decline in the M spike or an improvement in the immunoglobulins and the serum free light chain ratios, if I'm not seeing an improvement in those numbers, I might say to myself, and there are criteria that have to be met to define response. If I'm seeing that patients are not responding, we might have to think of alternate therapies, like changing the whole thought of what treatment are we giving this patient.
Thinking about that, so relapsed, refractory, not responding to therapy in general, how is treatment chosen for individuals in these situations?
So that's a really, really tough question and a very important one. And I think that term shared decision-making is a very important term, especially in the oncology setting right now. And I think especially for individuals with relapsed or refractory myeloma, this has to be a very in-depth conversation with the team. So the patient, the caregiver, and the provider and the supportive care team should sit down and look at what's our next step, right? And what is our next step? Well, we look at prior treatments. What has the patient received? How had they responded to those classes of agents? And really, how did they tolerate them as well? I think that's really, really important. So what treatments did they get? How did they respond? How did they tolerate them? And then also looking at risk factors. Relapsed myeloma, how is it relapsing? Is it relapsing because the M spike's just slowly going up, or are we seeing evidence of extramedullary disease? As patients live longer with their disease, this journey can be very challenging with multiple relapses and remissions. And then, of course, we look at comorbidities. As patients live with myeloma, they may develop some lung disease. They may become a diabetic. They may have some cardiac issues. They may develop with age some age-related comorbidities that we now have to take into consideration. I think, Lenise, what's really important as well in that shared decision conversation is, to some degree, I've seen a lot of different conversations in my lifetime as an oncology nurse practitioner, but you also want to deal with the patient preferences, right? We do want to get their disease under control. We want to make them live a long, good quality of life, but do they want to come to the clinic once a week? Is it a far distance? Is geography a problem? Do they prefer not taking oral chemotherapies at home? Do they prefer a sub-Q or IV? Or maybe they do prefer just the oral agents. We have to kind of think about what the patient's preferences are to some degree and kind of incorporate that in our decision-making plan for treatments for relapse and refractory myeloma.
So I think along with that, I think it's always really important also anytime you're having to shift what you're thinking or looking at what are the goals of this care and what are the patient's plans and thoughts related to that. So I think the shared decision making is huge.
Absolutely. I definitely agree that it should be a conversation that is together, that everybody is taking a part of.
So you talked a little bit about stem cell transplants. What are some of the factors that are used to determine whether a patient is eligible?
This could be debatable depending on where you are working or seeking care. But in general, there are certain factors that are taken into consideration when we determine if a patient is eligible or ineligible for an autologous stem cell transplant. And, one of them, of course, is age. And I don't like to put age as a sole indicator because I think that we all know that there are, as an oncology nurse practitioner, and all of the listeners might know that they have some patients who are 65 and have a better performance status than some of their 40-year-old patients. So age is a factor, though. It is a factor. And some of the other factors are organ function, and that goes in line with comorbidities. How is their lung function, liver function, kidney function? Do they have diabetes, CKD? Do they have COPD? We always look at comorbidities. We look at their performance status, that frail versus fit. Are they a 70-year-old that is still working full-time or part-time and taking care of their grandchildren some of the weekends and golfing and vacationing whenever they get a chance? Or are they very frail, where the patient may be very immobile, needs a wheelchair to get around, does not participate in any other activities outside of the home? So that also comes into play. Another factor for deciding whether patient is eligible or ineligible for a transplant is not just directed at the patient, but directed at their social support network. So if you have a patient who lives alone, has no family, minimal friends, maybe his friends live geographically, they're very far away. That could be a challenge, transplanting that patient. So we also have to look at their social support network and to see if they have the kind of support that they are going to need, especially in the beginning when they're first going through the transplant and first getting discharged from the transplant procedure. So I think all of those factors kind of come into play as to whether or not a patient is eligible or ineligible to proceed to getting worked up for an autologous stem cell transplant.
Yeah, it's interesting because a lot of times with most of our other therapies, we think about their social support, but it doesn't play into this, but definitely it does with transplant. Can you highlight some examples of emerging therapies for multiple myeloma?
I think it's important to note that myeloma is a disease that has had an amazing amount of research and advancements over the past 2 decades, almost 3 decades now. It is amazing in the amount of clinical trials that have been done and that have led to many new FDA approvals for single drugs and for drug combinations. So when I think of some emerging therapies, I think of some therapies that have already been approved. And by that, I mean the immunotherapies like our CAR T therapies, our T-cell engager therapies, our bispecific T-cell engagers. That's fantastic, great, efficacious group of agents. I think about antibody drug conjugates, these are drugs that are already FDA approved. But then I think of things that are not yet FDA approved. So some of the emerging therapies that listeners should be aware of is new classes of agents that I anticipate will be approved. I can't tell you when, but I know that there are active clinical trials ongoing with drugs like CELMoDs. CELMoDs are the new oral anti-cancer agents for myeloma that have shown great promise with efficacy and safety profiles. So we have to be on the lookout for these agents. And then there are other combinations that are very interesting that are showing a lot of promise. So drugs that are already FDA approved, and I'm talking about pairing like anti-CD38 monoclonal antibodies with bispecifics, with the bispecific T-cell engagers. If you do that, there has been some evidence that these responses are these combinations are very efficacious and responses are durable. And there is ongoing clinical trials and studies being done right now to kind of see if these can be FDA approved, to kind of pinpoint where they are as far as in comparison to other treatments.
It's kind of an explosion of wealth of treatments and what's going forward for myeloma. That's so cool.
And even in other cancers, Lenise, when you think about the targeted therapies, I mean, now we're even doing that with myeloma. We have a lot of small molecule targeted agents, BCL2, anti-BCL2 agents. We have drugs that target other intracellular pathways and mechanisms. So it's very interesting what's going on in the field of myeloma research.
Where can nurses go to find clinical trials that might be available?
I think nurses really should be aware of this because nurses might get this question from patients. They might say, well, my provider told me my disease is not really responding the way they would like it to, and I might have to consider other treatments. And I do want to mention, Lenise, which I probably didn't mention earlier in the podcast, but at any time in a patient's journey for myeloma therapies, we should always consider participation in a clinical trial. A lot of clinical trials, I want to say most of them, although not all of them, most of them are for the relapsed refractory setting, patients who had prior treatments, but there are some clinical trials available for frontline therapies. But I think especially in the relapsed refractory setting, that we should absolutely consider participation and enrollment in clinical trials if the patient would meet eligibility requirements. Nurses might get this question from a patient or even a caregiver. My husband, my father, my brother, whatever is relapsing. We want to know where to look. And there's a lot of different sites that patients can go to and nurses. Clinicaltrials.gov is a very large site. It covers clinical trials for all different diseases, including malignancies. But if we're looking for specific myeloma clinical trials, I think that going to the foundations is really critical. I think the IMF and the MMRF websites have places to go on their site where you can research clinical trials. I think the IMF has paired with Spark Cures. And I remember meeting with the owner of Spark Cures many, many years ago when he was just getting this program, this, I guess, passion of his off the ground. I think he had a family member who had myeloma, but he actually now is collaborating with the IMF. It's called myeloma.org/Spark Cures. So that is an excellent way to navigate which trials are available for multiple myeloma specifically and at what institutions they are available. So that's another very good site to go to. And of course, there's also the NCI, the National Cancer Institute, and like I said, MMRF. There's a lot of different sites where you can find different clinical trials that are available and also finding out which institutions are offering those specific clinical trials, because not every clinical trial is offered at every academic institution. So that's what I would say.
Exactly. Finding something that might be local to you so that you don't have to travel can play a huge part of that. So you talked about pain being one of the symptoms a lot of times, or one of the things that patients are dealing with and that it can improve over time. It's pretty common. What can nurses recommend to help patients tolerate it, or what can they expect to see in managing that bony pain?
So I think it's important to remember and realize that bone pain is the number one presenting sign for patients with myeloma. If they're clinically symptomatic, their problem is going to be bone pain. That is number one. It's usually their back, but it can be their sternum, it could be their hip, it could be their femur, but usually it's their back. So very, very common symptom. Patients with bone pain, what do they want to do? They want to obviously get relief from their pain. if they have a diagnosis of active myeloma, the first thing to do to address the pain is to start prompt treatment. Yes, we do need analgesics, but starting treatment promptly is the way to get the pain under control. So what I recommend is that patients start treatment and they should be compliant with their treatment schedule. They can use analgesics. I think that it's important to realize too, that as I mentioned previously, dexamethasone is an integral part of our treatment combinations. It is in every single treatment combination, especially in induction therapy. And dexamethasone has a very potent anti-inflammatory effect. And just giving patients dexamethasone as part of their treatment regimen can really help alleviate some of this bone pain. So that's a help. But they can take other analgesics with their provider approval. So we do tell patients they can take Tylenol. Usually we try to avoid NSAIDs because of the effect on the kidneys. We don't want to impair renal function any further, especially in a newly diagnosed patient. But then we can prescribe other analgesics like opioids to try to get them through the painful initial bone issues. And then when they respond to treatment, we do expect that the bone pain will lessen. And I always tell patients as well to try to participate in safe, and I want to stress safe, physical activity. So I tell patients the more you sit on the couch or you sit in the chair for most of the day, that unfortunately will make your pain worse. So trying to get up and about and doing some physical activity, even a physical therapy course, getting a physical therapy evaluation and a treatment program, no matter how passive or mild or gentle it is, can really help these patients with bone pain.
So talking about treatments, you talked about the doublets, the triplets, the quadruplets, and a lot of those are very big classes that we know can be fairly expensive. So can you talk a little bit about financial toxicity, how it might affect patients during their long-term journey and how you can work around it or assist them?
Unfortunately, financial toxicity affects every single patient with cancer and not just myeloma. And especially now, Lenise, that we're seeing the huge explosion of the oral anti-cancer drugs. And we all know that the oral agents come out of a patient's prescription plan, not necessarily their traditional health insurance, that covers IV or sub-Q administration of drugs. So it's a big player. And a lot of these drugs, as I mentioned, are now oral. But overall, even patients who are getting subcutaneous or intravenous injections can suffer from what I call wallet toxicity. I think when you think of this, you think of out-of-pocket costs, copay for drugs, copay for visits, travel expenses. Think about lost wages. People have to, if they're still working, and a lot of our patients still are working, whether it's full-time or part-time, they're going to lose wages from their job. Their employer, they're going to have lost wages. Some patients may even have to dip into their retirement savings. So that's another financial toxicity that patients are presented with. I think a lot of these agents are oral. So I think the biggest problem or challenge is getting some assistance with the oral agents. We do have, and I think a lot of academic institutions and maybe even some of the smaller institutions do have a social worker or a case manager or even a nurse or maybe even a non-medical team member who can assist with navigating the resources available for patients, whether it's foundation resources or pharmaceutical resources, to help with these different financial challenges. Because what are patients going to do? They're going to be forced to make difficult decisions. They might skip some of their medication. They might, unfortunately, skip meals to pay for a medication. I mean, I never like to hear this, but it is true for a lot of our patients. And one final thought on the financial toxicity, I think that it's important to remember that in our country, medical debt is still, unfortunately, one of the major reasons for bankruptcy. So I think that it is a very important thing to bring up to patients. Again, having a social worker or a case manager address these issues right up front so we can jump on trying to get all the possible resources and grants and whatever we can to help the patient right up front on board so that they can have less stress during their treatment journey.
I think that's really important. And then I'm going to put a plug in for ONS advocacy and some of the work that we do with Hill Days, where we've been up and have gone on the Hill and talked about how we can close the gap for those prescription benefits.
There's a lot of organizations, ONS being one of them, that are really, really trying to be strong patient advocates to try to get better sort of parity when it comes to oral agents versus agents administered intravenously or subcutaneously, and to try to help patients with cancer have better financial means or access to help with copays and stuff like that.
Exactly. And this has been great talking about myeloma treatment. I have a few closing questions. We talked about these in our first podcast, and we know it might be duplicate, but I think there's some extra ones in here that we can talk about. So how can healthcare professionals evaluate or look at their own hidden or maybe implicit biases about multiple myeloma treatment?
I think we all, unfortunately, have hidden or implicit bias inherently in ourselves. But I think it's important to remember that regardless of a patient's socioeconomic status, if they are given the right options, the right treatment, the right opportunity to enroll or participate in clinical trials, you have to understand that outcomes for everyone improve. So we have to kind of just look at the patient as a myeloma patient. Yes, everybody has different challenges, but just really realizing that everybody should be able to have access to all of these novel therapies, these novel combination therapies. It doesn't matter where somebody lives. If they're in a rural area, if they don't have a certain income, we're not just going to give them a doublet when we know it's not going to be as efficacious as a triplet or a quadruplet therapy. So we have to really be strong to get our patients the correct treatment, especially frontline treatments, and even access to transplant. We have to be our patient's advocate sometimes for them, right?
Definitely. That's what we're known for and what we're best at. What are some common misconceptions about multiple myeloma treatment?
So when I was thinking about this, I think that some of the very common ones are still some that I see right now, right today. Stem cell transplants are only for young patients. They're only for the young patients. Stem cell patients can't be given to older patients. That is a misconception. We have successfully transplanted patients who are older, who have good performance status, few comorbidities, if at all, who have a good, strong social support system. So stem cell transplants can be for all age groups. I mean, there are institutions who will set an upper limit. I'm not talking about, a 90-year-old, but I'm talking about either patients in their early 70s who might be eligible for transplants. I think some of the other misconceptions is people hear about CAR T therapies, right? Oh, CAR T therapy, you're months in the hospital, and then, it's precautions are lifelong. I can't go out, I have to be in a bubble and I can't go outside for like months. I mean, a lot of this is misinformation. So CAR Ts do not need months in the hospital. CAR T therapies, they are hospitalized for a certain time frame, but certainly not for months. And, precautions are needed, but not total isolation. And as patients go along and time evolves, the restrictions become less. So I think that's important to note as well. Modern treatment options offer so much better disease control and quality of life that patients can be in a very long-term remission. So I think that some patients will read stuff online about how it's the death sentence. And that really bothers me because patients can live so long with myeloma if they are compliant and if they are staying on board with their treatment team and they're compliant with their visits and stuff like that. They can do very well for a very long time.
So really good points. What are some additional training or education that oncology nurses need to stay current on this topic?
There's so many drugs and drug combinations, new drug combinations that are in clinical trials and being studied now. And I think it's really important for oncology nurses to try to stay abreast with what's being FDA approved. And that's sometimes difficult. I know that the FDA itself and the ONS will send like little email blurbs out there when something is FDA approved. You get sort of an email or you might get an alert or I think it's important to stay as best as you can up to date with the newest, latest, and greatest treatments. If your facility, if your institution does allow pharma reps to come in and to talk about the new treatments, that's also a help as well. You can get information from them. But I think it's important to stay on top of what's being studied and ultimately what is getting FDA approved, because I have to tell you, Lenise, myeloma patients are very savvy. They will know about these FDA approvals before I do. So They come in and go, oh, I just heard that, XYZ drug or drug combination was approved. When can I get that? I'm like, oh my God, I didn't even check my email yet. It's amazing. So that's the one thing I can recommend to try to stay up to date with all the FDA approved stuff.
Have your light morning reading of signing up for your FDA alert so you can see what happened overnight.
Yeah. Uh-huh.
What are some other additional resources for patient and providers who want to learn more?
I'm going to refer back to the foundations like MMRF and IMF and even ONS. I mean, especially for nurses. So the patients and nurses can go to the foundations, but the nurses can go to the ONS. I think if you occasionally want to just log on, and sometimes you'll see new information that's there that you weren't aware of. So I think some additional resources might be going onto the website, getting the printed materials or digital, looking at it online, like the publications. I know they all have publications that come out periodically. I think trying to stay abreast. I know it's hard, especially if you're not a myeloma nurse or nurse practitioner. You have so many other diseases to follow as well. And it is a challenge. Think about all the oncologists, especially in the rural areas that have to treat everything. I just don't know how they stay up to date with everything. It's tough. There's so much new advancement and stuff that it's very hard to stay abreast with everything.
Exactly. Once again, it has been awesome talking to you. Do you have any final comments for us, Anne?
I just think it's important to realize that myeloma has had amazing advances in science, research, and treatment. I think that all of these things coming together, all the science and clinical trials and everything like that, have led to a significant increase in overall survival of our patients, which ultimately is a great thing. We want patients to live longer, and they're living longer with a very good quality of life. So I think it's important to realize that myeloma is very well studied, very well researched, and it's still ongoing with many, many clinical trials.
As a heme nurse, it's exciting for me to see the advancements that have happened and what is coming. Thank you so much for talking with us, Anne. Have a great rest of your day.
Thank you so much, Lenise. It's been my pleasure.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.